What's up, YouTube? Welcome to another episode of the Undergrad Forum. Now, today is a video that I have been promising you guys for a while. It took some time to do, but it is finally done, and that is the complete physical exam brought you by two medical students who probably don't have the competency to be making these videos, but it's for educational purposes and for fun, so watch them at your own discretion. So here's my classmate, Richard.
You can call me Dick.
All right, we'll call him Dick. And so we took the time to make a full examination video. As medical students, we're learning how to do the full physical exam. And we thought, well, since we're practicing, might as well put it up on YouTube as kind of a general guide.
Yeah, and I would say as a disclaimer, when you go into clinic, don't use this as your be-all, end-all guide. This is just like a quick introduction to the physical exam so for you MD students or PA students or nursing students, whoever, it's a nice introduction. You can get a feel for how the flow should go.
That's right. Do not rely on this as your primary source. If you do, you'll probably make a lot of mistakes,
Yeah,
which tells you how. It's a good video, but of course, read your textbooks and listen to your attendings. All right, so the physical exam, we're going to start off with an intro, and we're going to be voicing over the whole thing. So stay tuned, guys, and enjoy the video. And as always, enjoy your studies. Get out of here. Alrighty, so here we are. We got Dick there on the table. You got me coming in, my handsome white coat. Where am I? Where am I? There I am, gorgeous me. Took a shower that day. All right, so make sure you come in, greet the patient.
And a nice paternalistic pat on the shoulder, make you feel comfortable.
Patients love it. It's a nice feeling, but don't forget, tell your patients what you're going to do. Tell them, in my case, I tell them I do a head-to-toe exam, kind of explain things that are going along, keep them in the loop, otherwise they feel kind of bored and they don't know what's going on. So here's the beginning. This is general head inspection. Ask the patient, are they losing any hair? Do they have any rashes? Have they felt any dandruff lately? Now we're kind of doing the palpation.
So what we're feeling for is just irregularities in the skull, bumps, soft spots, that sort of thing, tender spots.
All right, so our patient was good here. So now we're moving on to the eyes, looking at for hair on the eyebrows, eyelashes, any kind of loss.
Yeah, just general discoloration, health in the skin in the area. There we were looking at conjunctiva.
So this is kind of a fancy technique. We just do like tangential lighting just to get a better view of the conjunctiva and the iris. So there we're asking the patient if they have any kind of gunk coming out of the lacrimal glands or any kind of weird pus or any kind of pink eye. And here we're actually going to look at the lacrimal glands by having the patient look up to get a good look in there.
So here's a vision test. We're going to be testing the eye as well as possible problems in cranial nerve 2.
So what you want to do is have the patient do one at a time. And the trick here is that once they read one with one eye, have them read the letters backwards with the other one. It's a nice little trick you can do. And make sure they're wearing their glasses or contacts. All right, so now we're going to move on to doing direct and consensual light response. If you don't know what that is, look at your textbook and read. But anyways, you want to do both eyes, both looking at direct response and consensual. So this is our accommodation test, where we're going to have the patient look at my finger up close and then look at something far away. And what you're going to be testing is to see that the pupillary constriction with the close object and it kind of dilating far away. So you want to look at both eyes when you do it. So now this is called the nose to finger test, testing the cerebellum and probably some other fancy things I don't know yet. But you don't have to do this many. Just do like a few, but make sure to do both hands. I forgot to do both.
So here we're going to be checking the exterior of the ear, checking for any problems with the skin. You're going to ask if there's anything oozing out of the ear, any pain, discomfort, heat, anything of that nature. And then after you check the exterior, we're going to look at the interior with an otoscope. So
it's a really fancy little device here. We happen to have a good one on hand, but make sure you put the little cover on. And do not jam this in the patient's ear. They don't need to go to get ear surgery because you're doing a physical exam because you messed up. Just kind of tug on the ear a little bit superiorly, posteriorly. Just gently put it in there. And pulling on the ear just kind of straightens out the canal so you can see the eardrum a little better. So do both sides. It looks really nice. And
also note that earwax, although unpleasant, is normal.
That's right, Dick. Don't make your patient feel bad about that. All right, so now we're going to do a cranial nerve 8 hearing test in which you're going to rub your fingers on either side of the patient. A nice little trick is to do the same side twice, just to kind of see if they're on, pointing at the right angle, the right side.
All right, so here we're going to do a general inspection of the mouth. So on the exterior, we're going to look at the lips, bleeding, cracking, any signs of cyanosis with blue coloration. Inside the mouth, gums, teeth, soft palate, hard palate, looking for lesions, discoloration. Uh, and now we're going to be moving into a test of facial nerves. So here's cranial nerve 7 with a smile. And then here is cranial nerve 12 with the hypoglossal with tongue movement. We're going to check having the tongue come straight out as well as bilateral movement.
That also checks a lot of other components. And now we're going to move on to the neck and to the throat. We're going to do general palpation. I noticed something kind of weird there. I think Dick has like some old football injury, yeah, when you were young. But now I'm just kind of checking the trachea, see if it's any kind of at a weird angle. If it's dislodged, as they say, we kind of just check all the general bones in the area. So now I'm doing the actually, this is good. This is your lymph nodes test. I did parotid gland, a lot of different stuff I'm doing. Look up the lymph nodes if you don't know them in anatomy. But just kind of get this full on. If you don't remember all the lymph nodes, just remember the fact that you're just going to check everything below the neck, kind of around to the shoulders. So here, now I'm checking cranial nerve number 11, spinal accessory, by having them, this is S sternocleidomastoid, and the other one was a trapezius superiorly to have them go up. So now I'm moving on to the thyroid. I'm just kind of looking at the thyroid gland to see if anything's kind of like a goiter kind of thing, but nothing on Dick here. And just kind of looking at it, giving a general appeal. Or general appearance.
Now you're creepily moving behind me so you can
Yeah.
feel the thyroid with both hands.
And
And he's going to have me swallow. And as I swallow, the thyroid gland should gently come up and you should feel it beneath your fingers.
right, so now I'm actually going back to doing more cranial nerve number 7, where I'm testing a lot more my memic muscle. So smiling, frowning, showing his teeth, puffing out his cheek, and make sure you push to see that he can hold the puffiness in tight.
So here we're checking muscles of mastication, which is going to be cranial nerve 5. Make sure the muscles come out.
All right, so now we're going to move on to the next stage, in which we're going to do the so this is considered, what is it, like cranial number 5, facial for sensation.
Yeah, so it's cranial nerve 5 in the face.
So this is trigeminal. It's called trigeminal because you have V1, V2, V3. And now I'm just testing. So before I started this, I rubbed a sharp object in the patient's hand and a soft one to let him know what it felt like. And now I continued from the face, which was trigeminal, down to different dermatomes of his body. So this is kind of how I do it. You can do it more detailed. But we did trigeminal. We're doing shoulders now. We're doing the inside, the outside, the biceps, the forearms, the hand. You kind of get the idea.
And an important note is that you should have the patient close their eyes, because if their eyes are open, they might be seeing if you're pointing the sharp or the blunt object on their skin, so they could be kind of cheating.
Yeah. So in this case, I had a little fancy little like sharp pen, and like it had a dull side to it. But most times I just use like a cotton swab to break the handle in half. I just didn't have a cotton swab and I had a really fancy pen, so why not? So as you can see, so you'll learn in anatomy all the dermatomes. Once you know the dermatomes, you don't have to really memorize this. You can just kind of hit all the points you want. So that's the upper limb, and recall we go from the face down. This is just the way I do it. It's just a lot easier. So now we're going to do the lower limb, and now we're just kind of starting there on the thigh, moving down the leg.
Dude, those are some big thighs.
I know you work out way too much, man.
So again, we're checking the dermatome map throughout the lower limb. And you don't have to touch quite so many times on the lower limb. Just make sure they have feeling, throughout the lower leg and the feet.
Yeah, this is really discretionary. Like you can really go bare. I kind of tend to go a little bit over, just because in my mind the dermatome map's is like really important to go through. All right, so now we're going to do some eye stuff. So go ahead and tell a patient cover one eye, and we're going to have them ask. So we're going to bring my hands in and wiggle, and we're going to say to the patient, when can you see it? And the important thing here is that you yourself, as the practitioner or the person, are like the standard against your measuring.
Yeah, so this is going to be testing for peripheral vision, which is going to be implicated with cranial nerve 2.
So I kind of make like a bowl shape with my hands. That way you don't have to memorize it. It's just a nice way of doing it. So now we're going to do, so we're going to make an H with our hands, and we're going to have the patient look. And when you kind of go at the edges and go up, you want to look for nystagmus in the patient's eyes.
Yeah, so this is movement of the eyes, which is going to be cranial nerves 3, 4, 6.
And at the end, if you saw, I kind of brought my fingers in towards the patient's nose to do accommodation. So now we're just going to do a general inspection and palpation of the back and the neck. So I'm inspecting, i.e. looking with my eyes. This is called palpation. All right, so now I'm just now I'm telling them, okay, so now I palpated, I'm going to percuss. So percussing is kind of a fun thing once you kind of get it down. You can get some really loud sounds. Maybe you can hear mine right now. So you want to percuss in a bunch of different quadrants. There's a specific number, but I kind of tend to go a little bit overboard as opposed to under.
Yeah, and again, if you're doing a full pulmonary exam, you're going to do more percussion to test the level of the lungs bilaterally,
Right.
make sure there are no problems. But again, this is the quick physical exam, checking for major issues in a healthy individual.
That's right. You don't need to go as detailed as I sometimes do, but it never hurts. So now we're just going to be auscultating with our stethoscope, having the patient breathe in and out each time with the stethoscope through their mouth. And make sure that when you tell the patient, or at least you as a person, should not be lifting off your stethoscope unless they've done a full inhalation isolation cycle. Don't short it. Really big thing, make sure your stethoscope is on the bare skin. Do not put it over a shirt or jacket or even the gown.
And what you're really checking for here is, differences in the lung quality from one side to the other, or for just, strange disturbances like, mucus buildup or things of
Or
that nature.
bronchitis or pneumonia, a lot of different things you can hear. So if you hear crackling, wheezing, a lot of those are going to be red flags for you to do a little more of a pulmonary exam. Clear sounds just kind of sound like like air going through like a tube or something. So that finishes that. So now we're at a third. Okay, this is important. Now we're doing the anterior chest of pulmonary. You have to have the bed at 30 degrees. That's how we do it. So for up to the exam till now, they've been sitting. So here we kind of made a makeshift 30-degree angle thing, and now we're doing the anterior chest. And again, you can see his chest going up and down with each breath through his mouth. And again, here I'm doing, I tend to, again, overdo the quadrants, but you really only need to do about 6 bilaterally. I think I go over, but it never hurts.
Yeah, I think you could even get away with fewer than 6.
Yeah.
Yeah, just make sure you hit the major areas above the chest wall.
That's a good point. I mean, for me, I kind of like to build like a map in my mind of where in the lungs I've heard. So if you just think back to anatomy where you have the lungs in the chest, you can kind of think of little spots where it's clear here, clear here, clear here. And so again, I'm going overboard, but I kind of like listening to lungs. Here, I go really at the sides, just because even at these sides, most people tell you can't hear well, but in someone as young as Dick, like taking a deep breath, you can still hear his lungs. All right, so make sure to cover the patient, keep noise comfortable. Okay, so now we're going to do what's called JVP, jugular venous pulse or pressure. Okay, so this is like the far-away angle. I'm going to show you guys zoomed up. So right now what we're checking for is the internal jugular vein. And the way you want to know you're looking at internal jugular vein versus the carotid is put your hand over it. If you feel it pulsating, guess what? Not the vein. So once you've identified the internal jugular vein, look at it again, make sure you've identified it. Use a flashcard to find the meniscus for the very top of where it is, like where you see the pulsation of the internal jugular vein, and put the flashcard there and put the ruler over the sternum and measure how many centimeters. Most people say it's like normal, it's like less than 4.
Okay, so here we're going to be feeling for the carotid arteries, just making sure there's smooth blood flow up into the cranium.
And note to the wise, do not feel for both at the same time.
Yeah, your patient might pass out on you.
Yeah, so don't stop blood flow to the head with both at the same time. Right. So now you're going to take your stethoscope and put it right over the carotid arteries to actually hear. So you can actually listen for like bruits or other artifacts.
Yeah, and a little tip is if you have the patient hold their breath while you're doing this, your listening to the carotids won't be obscured by breathing through the trachea.
Yeah, it's an excellent point. Alrighty, so now we're going to do JVP and carotid again. So those are Dick's huge sternocleidomastoids that kind of make it difficult to see his internal jugular vein. But hey, what are you going to do? So here I'm kind of palpating to make sure I am feeling the vein as opposed to the artery. So there you go. I got a little flashcard I carry around. It happens to be purple or lavender.
Yeah, and I think in reality, this is an important test, especially for heart function, venous return. However, in a patient that's severely ill, you're going to see a JVP.
Yeah.
Before you get out your flashcard and ruler. But it is a good test. It's good to document.
And make sure that the bed's at 30 degrees. That's key. And if some people think what they call JVP, like the internal barometer.
Oh, yeah.
I like that. It's kind of romantic, right?
Yeah.
All right, so here, carotid arteries. I mean, you can tell I push a little bit hard. I mean, I told you, Dick's SCMs are freaking huge, so I had to really get in between to feel the carotid arteries. So here I am with the stethoscope again, going in for a listen.
Yeah, and another note on the JVP versus the carotids is that you're going to see the internal jugular vein just to the exterior of the sternocleidomastoid when the patient has turned their head to the opposite side.
Dick, it was kind of hard just because his SCM was so large, it made everything tough. So I didn't have him go as left as I wanted. All right, so now we're going to do anterior chest for pulmonary. This is general. I did the inspection while I looked at his chest, and this is palpation. I'm feeling for lifts, heaves, and thrills. What do those feel like? Well, have you ever felt a purring cat?
I don't like cats.
Okay, I don't care, but I do. So if you feel anything, okay, touch your own chest. You shouldn't feel much when you're breathing, but if you feel like purring vibrations or kind of the chest bumping against your hands, you're just kind of feeling for anything unusual. And now we're going to go back to auscultation. You may ask yourself, hey, didn't you already do like a cardio exam in this region or like a pulmonary exam? Never doing cardio? Well, yeah, you could probably knock both out at the same time, but I didn't. I mean, yeah, in reality, what you would do is you would do cardio and pulmonary almost simultaneously. Have the patient breathe, listen to heart, but
Yeah.
we split it up just for the video.
And you're going to be listening. The different spots he's hitting include like aortic valve,
Yeah.
pulmonary valve, and then a couple of spots along the left parasternal border.
So what I did there was I tried to feel for like the PMI or the point of maximal impact, and then just put my stethoscope over it to hear the mitral valve. So feeling the PMI, if you can't feel it, have the patient turn over to the left side. It usually helps. But Dick's pretty young, so it wasn't that tough. So now moving on to pedal pulses, dorsal pedalis, and the posterior tibial arteries. So there in the tarsal tunnel, you're feeling the posterior tibial artery. Check bilaterally, see if they're kind of even.
And again, it may seem a little out of order that he's going from my chest down to my feet, but this is just part of a thorough cardiac exam. So making sure I have nice perfusion down to my lower limbs.
Right. So normally I wouldn't do this because I don't want to touch a patient's foot and then touch their stomach or chest again. They may feel uncomfortable, but just for the sake of keeping it logical, that is part of the cardio exam.
So here we're moving into an abdominal exam. And an important note is that though you're at 30 degrees for cardiac exam, if you're
anterior pulmonary.
And anterior pulmonary. If you're going to transition to the abdominal exam, you want to put the bed flat at 0 degrees so you're not going to disturb any bowel movement or bowel noises.
And the big thing here, if you notice, the first thing you do in abdominal is auscultate. You don't palpate or percuss or anything else.
Why is that?
Just as you said, just as you want to keep the patient's bed flat to not disturb the abdominal sounds, you also don't want to percuss or disturb anything to start with.
Right, yeah. So if you're, palpating and really pushing on the intestines, you can affect gas throughout the intestinal tract.
Right, so you can mess up what you're actually going to hear. You can create artifacts.
Exactly.
So after auscultation, we do palpation in the 4 quadrants of the abdomen.
Or percussion, rather.
Yeah, percussion. What do you mean? What did I say?
Palpation.
I meant my percussion. Yeah. Okay, so now I'm percussing the border of the arterial liver to see, what am I doing here?
You're checking the span of the liver. So what you should be hearing is a nice resonant sound below and above the liver,
That's
and
right.
then a dull sound as you're percussing over the liver.
That's right. That's exactly what I meant to say. All right, so now what we're doing here is doing a light one-handed palpation and then a deep double-handed palpation. And the big thing here is notice what I'm doing perfectly, looking at the patient's face to see if they have any kind of discomfort. That's the big thing, because they could just squirt, like make weird faces and not tell you when they have pain.
Yeah, so here we're moving into a deeper palpation.
Specifically of liver and now spleen. So have the patient take a deep breath in, and when they're letting it out, push in that in this one to feel spleen and previously to feel the liver. And go ahead and keep the patient covered for decency. All right, so now we're going to take Dick here and we're going to tell him, and tell your patient what you're doing. I'm telling you, okay, now I'm going to inspect your back and neck. So now
so this is going to be part of the musculoskeletal exam. So he's feeling down my paraspinal muscles on the actual spine itself. Mainly just checking for tenderness, any strange lumps, bumps, that sort of deal.
So I tend to overfeel things. I mean, I did SCM again, as you noticed, which I've already done it previously when I was doing the neck exam. It never hurts to check things more than once, I guess, but it's not very efficient if you're low on time. All right, so now we're going to go all the way down the back. So
we did cervical spine before. Now we're moving to thoracic, lumbar.
Right. Don't forget to cover the patient. Okay, so that was just a back inspection. So now we're going to actually look at neck range of motion. Have the patient look down, have them look up. And so these are all just different muscles that are in the neck. And the patient will tell you either they can't do the range of motion or they feel pain with these range of motions. And Dick's doing all right. So now I'm going to actually inspect, look at, and then go for the actual shoulder region. The way I do it, I go right at the sternum in the middle and palpate out. So go across the clavicle, go across to the joints of the shoulder, really just go straight across and feel all the parts. So this part, you want to kind of take the arm back and feel for the subacromial and then the what's the other bursa? What's some other bursa? Okay, now
And
here
then
we're
here
going.
he's checking for the biceps tendon insertion.
Right, so I usually have the patient flex, and then I have them relax, and I feel it just because it helps me find it. So Dick here is one muscular fellow, so it's a little bit easy to find the biceps tendon, but if you have a elder patient, it could be a little tough. All right, so that was that part. Now let's move on to the, now we're going to do range of motion for the shoulders. And as you can see, it's just a fun game of moving arms about.
Yeah, what you might find here is a patient maybe with a rotator cuff damage, and they're going to have real trouble lifting their arms in certain directions.
I actually saw one of those a while ago. It's pretty cool. So here, I call this the combing your back hair. So I'll have the patient do it twice. And now we're going to be inspecting the elbow. This, you really just have to know your anatomy. Once you do, you kind of know where to touch for the bones and ligaments. It kind of just looks like you're feeling around, but you kind of want to go in a methodical fashion for yourself. You have to create one for yourself here for the tendons, the ligaments, and the different bones and joints.
Yeah, and another note, it's important to continue to ask the patient, do you feel any pain? Is there any discomfort? Just because they might be shy, they might not be willing to say, oh, it hurts, even if it's just a little bit.
That's a good point, because not everyone's going to be very willing to talk. So there was range of motion for the elbows. So now let's move on to the radial carpal joint, aka the wrist. And here, I mean, the wrist bone, God, it gets so confusing as heck. But yeah, just go ahead and feel it. Feel for all the bones. Feel for discomfort. I apply a little bit of pressure laterally, medially, just probably a little more than I should. But because sometimes people are a little bit shy about pain in their wrist because they get worried. So here's range of motion again. And it kind of looks like you're doing the Macarena almost, isn't it?
Yeah.
For all the people listening who grew up after the 90s, you do not know about the Macarena.
Yeah, the sound is muted on the actual video. There is tropical music playing.
So this is, just checking the hand, the bones and the finger bones. What do they call them? Tarsals, metatarsals, and phalanges.
Finger bones.
Finger bones. That sounds like layman terms. I like that. Why confuse things? And so a good trick here to save time, just kind of grab and pull down gently, and then you can just check all the bones and joints at once.
But be thorough and hit every joint within the finger.
But okay, so here I'm doing like a strength test. We do this again. I kind of jumped the gun this time, but you're gonna have the patient kind of extend their fingers and you're gonna press against. This is called opposition of the thumb, and so you're gonna have the patient make this little thing with their index finger, and you're gonna pull up and see if they have strength. See, sometimes you got to explain it a couple times because it's a weird test. See, here I'm doing it again, just to kind of give you a better view of it. See, and there it is. All right, so now we're going to move down to lower limb.
Okay, so here we are inspecting the knee. You're going to check all around the patella. So for the quadriceps tendon, common patellar tendon, or ligament rather.
Don't forget the popliteal fossa.
Meniscus, articulations between the femur and the tibia as well as the fibula. So
what was that one injury, the unhappy triad? If you have athletic people such as Dick here, ask about the unhappy triad.
Yeah, so say you're a running back and you take a shoulder pad to the lateral aspect of your knee, you're blowing your ACL, you're blowing your MCL, and you're blowing your medial meniscus.
Ouchies.
Yeah. Okay, so here we're doing some range of motion, active
internal
range
rotation,
of motion.
external rotation, extension, flexion. Almost done. Okay, and now we're moving on to the ankle. So here what you want to do is really just kind of go for the bones, like the bottom of the tibia and the fibula, which kind of creates what we call the ankle. Feel for the bone, feel for like the tarsal joints, Achilles tendon in the back, and really just kind of get it. Again, once you know the anatomy, it kind of looks like you're just feeling around, but once you know the anatomy, you know which joints and bones to go for. And so now, what are we doing? I don't know. What's up next? Okay, so now we're going to do some strength testing.
Yeah, so this is traditionally part of the neuro exam, making sure there's good innervation within the muscles.
And so here we're testing wrist, extension, flexion. The previous one was elbow. Here again, the hands. So now here you have flexion of the thigh, lateral deviation, medial deviation, check it for both. The nice thing when you do it like this, you can just have the patient sit. You don't have to keep moving them around. And now you're going to have the patient push down. Be careful if you have someone like Dick here with ridiculously large quads so they don't actually crush your fingers.
And don't be extra handsy like Mo here.
All right, so extension, flexion of the leg. Notice there's a distinction between leg and the thigh. If you haven't learned that anatomy by now, we got problems. All right, so now you're going to move on to the actual ankle. Again, flexion, extension. Fun things to do is say bring your foot up and press the gas pedal real hard if you're talking to kids or something. They kind of enjoy things like that. All right, so now we're going to test for reflexes.
So I happen to be a patient with not the best of reflexes.
Not the you have the worst reflexes in the world. Look at
That
him.
was a fake,
Yeah,
for the record.
Yeah, so there's your biceps tendon.
Yeah, so what you're going to do is you're going to find the biceps tendon, and you're going to place your thumb over it, ideally. Mo's not always doing this, but if you have an older, more frail patient, you want to place a barrier between their tendon and the hammer. Because if you need to use some force to get that reflex, you don't want to give them a bruise or something like that.
Right, so that was brachioradialis. So first we did biceps and triceps tendon. I'm doing brachioradialis. I know that Dick has the world's worst reflexes, so I'm not sitting here hitting it a million times. I already know it's not going to work. So that one worked, though. Here's a patellar tendon reflex.
These are genuine.
Yeah, but I mean, if you already know your patient's going to have horrible reflexes for a recording video, I'm not going to spend hours doing it.
Yeah.
So Achilles tendon here.
And a clinical note I've noticed by the number of patients I've seen is that a lot of males actually do have poor upper limb reflexes.
Yeah, I don't know why, actually.
Yeah.
All right, so now we're going to do some walking tests. So actually, this is still like back and spine stuff. So range of motion. So having bend forward, having them bend back. Make sure you support the patient. If this is an elderly woman, if she falls over, that's not good.
Or elderly man.
Man, what? You get my point.
Yeah.
So now we're going to do rotation, trunk rotation, and I should be supporting the patient, but Dick is pretty fine, so I don't tend to do it. So now we're going to watch the patient walk to see if they have any kind of gait.
Abnormalities.
Yeah, any kind of like those funny Trendelenburg gaits or anything else.
Yeah, so
those mid-team gaits are pretty interesting too. But here, so we have them walk like they're on a tightrope. That's why I tell patients, just because they understand it a little better.
Yeah, and this could elucidate any problems, maybe with lower motor neuron or an upper motor neuron.
Excellent
if
point.
they had bad balance or something of that sort.
Or cerebellum stuff, yeah.
Yeah.
So walking on the heels, walking on the tippy toes. All right, so what do you got next here? So that was it. So make sure to wrap up with the patient, tell them how things went, good, bad, and most importantly, ask them if they have any questions.
Yeah, and don't forget to give them a firm handshake and a pat on the shoulder.